Great. So, oh, sorry, go ahead.
Do you want to click?
Oh, I get to do the click?
Yeah, if you want.
Oh, sure. Thanks. Thank you, Kaylin. Okay, so I wanted to talk about stigma today and the role it plays in our field, because frankly, I just don't think we can talk about it enough. I think the more that we talk about it, the more we can become aware of it and help others become aware of it. That's just consistently, constantly helping our role in fighting it. So that was why I just wanted to briefly touch on that today. Oh, I get to be the clicker. Oh, wait, how's that go?
Is it on the, put it on the screen? Yeah. And then it should just let you click.
Oh, thank you. Sorry, that's going to take me a while. So what is stigma? Stigma is an attitude, behavior, or condition that is socially discrediting. Oftentimes the major influence regarding stigma with addiction are the beliefs about the cause and controllability. So it's our beliefs on what we believe cause the addiction and what controls the person or what control the person has over it. The words we've used have been shown by researchers to not only negatively influence our attitudes towards people in recovery and people who use substances, but they also impact access to healthcare and recovery outcomes. Research shows that addiction is the most stigmatized condition worldwide, and it's one of the few health conditions out there that some members of the public still consider just a moral or criminal issue. Clicking is going to be the most difficult part. Okay. So stigma occurs at many levels: the public level, the private level, and the personal level. People fail to access or engage in treatment because of fear of what people might think. They don't want to be considered a quote-unquote addict. The medical profession often fails to treat patients appropriately, like not using FDA-approved medications. Mental health programs may exclude substance use disorder patients. Funding for substance use disorder treatment is insufficient to meet the demand. Substance use disorder patients are frequently sent to prison rather than treatment programs. People in recovery are always under suspicion. And if patients have a criminal history because of their drug use, then this causes future stigma in terms of employment, housing, and educational loans. So ultimately, stigma becomes a barrier to acknowledging the program, accessing help, and helping our patients remain in treatment. Just for some examples, we want to take a look at our language. I know for a lot of the folks that participate in this project here over the years, you know, you guys have we've done a great job of over time trying to change out our language. So for example, where we used to use the terms addict or abuser, we try to use the term person in active addiction or person with a substance use disorder. The old terminology clean and dirty urine is now replaced with a positive or negative urine. The term replacement therapy, I will still hear from folks in the public, and I'm always, try to quick to replace that with medication-assisted treatment. Drug habit used to be, or that's what the term we used to call, and now we stick with substance use disorder. The war on drugs is also, to me, that was interesting. That's the old terminology, and now we really try to focus just on prevention, harm reduction, and treatment. I'm sorry. No, just me. And then, in the past, we used to only hear folks introduce themselves as, hello, my name is John and I'm an addict. And now we will often hear folks using different terminology. For example, hello, my name is John and I'm a person in recovery. I teach an Intro to Addictions course for the university, and one of the members of the collegiate recovery program comes and does a little introduction to the class just to talk about the program. And he specifically talks about that when he's out in public, he likes to introduce himself and he'll say, hello, my name is John and I'm a person in recovery, because it's his way of trying to help change that language in the general public. But that for him personally, when he still goes to AA meetings or NA meetings, for just his own recovery, he likes to introduce himself as an addict. So I like, him sort of taking charge of what fits best for him in the moment. I should have had you be my
Oh, it's okay. You should. Yeah, you can.
So as helping professionals, we have the opportunity to help influence stigma in so many different ways. So we can do so with our patients by helping them to reduce guilt and shame through the treatment process, by offering moral support, respecting confidentiality, adopting a non-judgmental yet accountable stance from the very first time we meet them, treating the patient like any other patient with a chronic illness. And I'll just take a second. Are there any other ways that you folks have learned over the years working with your patients to help reduce stigma with them? crickets. We can come back to that afterwards. And so as helping professionals, we have the opportunity to help influence stigma within our own within our own selves and with our coworkers by educating colleagues about substance use disorder being a disease, helping share stories of success. And then we can influence stigma with ourselves by being aware of our own biases, changing our language, and then finding support for transference issues that we're generally going to face. Maybe I'll leave some opportunity afterwards if there is any kind of open dialogue that folks want to have. So we have the potential to be so much more effective with our patients if we talk to them with compassion and empathy. Early on in addiction treatment, confrontation really used to be kind of the go-to model. And don't get me wrong, I still confront my patients on the reality of the situation they're in, but confronting them with force and aggression is really simply just a way to try to shame them into honesty. And instead, holding them accountable with respect, that's a way to communicate, I care about you enough to be honest with you. So we want to help educate them on the fact that addiction is a disease. The disease model of addiction shifts that national focus from blame to recovery. And under a disease model, addicts are not immoral, they're ill. We want to educate them on the link between trauma and substance use disorder. We want to show them why they deserve to let go of previous guilt and shame, because those are some of the biggest relapse triggers for folks. And then along the way, we want to hold them accountable for their actions, because we know that accountability is a great way to show respect. So I respect you enough to help you in this learning process. I think Laura, I'm not good with time frame. I want to say it was in the last couple of months that she talked about stages of change, but frankly, in my brain, the last couple of months could have been sometime in the last year. So I'm going to briefly touch base on stages of change, just in the context of how I use it in my role as a helping professional, but probably in the future it's really a good time to do another didactic just on stages of change. So when we're meeting a patient with an addiction, it can be most helpful to first establish where they're at in terms of readiness to change. So the stages of change model, also called the trans-theoretical model, that's something I utilize on a regular basis, on a daily basis. So I'm just going to review those stages here. They go from, there's the pre-contemplation stage. At this point, the patient really has no intention on changing their behavior. So maybe either they're in complete denial about having a problem, or they're aware of it, but just not yet sort of willing to make any changes. The next stage is the contemplation stage. So at this point, the patient's aware that a problem exists, but just hasn't yet made a commitment to changing it. Oftentimes I see the most fear at this stage, because the idea of change, the idea of taking a risk, is really terrifying. At the preparation stage, the patient has accepted there's a problem and is now willing to take action and start to make some changes. At the action stage, the patient is actively working on those issues, getting into and attending treatment, making changes in their life that support their goals, etc. At the maintenance stage, the patient has made sustained changes in their life with new behaviors and is doing the work to maintain those changes. And then at the relapse stage, the patient has either fallen back into old patterns of behavior, or potentially including actually using substances. And so for me, why I appreciate the stages of change so much is it really helps me keep track of where the patients are at and where I need to be focusing my work on. If I'm not careful, maybe I'm meeting a patient at a pre-contemplation stage and I'm trying to treat them as if they're in the action stage. And if I'm not careful, I'm going to accidentally shame them along the way, because maybe my expectations aren't the same as theirs, or my goals aren't the same as theirs. And I'm trying to pull them over to my side as opposed to trying to meet them where they're at. And so for me, keeping stages of change is one way to help reduce the shaming that can come from stigma. And that was kind of why I wanted to present it here. I think my last slide is just additional information on those stages of change. So those are my thoughts on stigma. Again, I feel like it's something we can talk about on a regular basis, because it's just a good reminder of what are we doing to combat it on a regular basis. What are some accidental kind of old habits that we're falling into with stigma that we can help each other be aware of? So I don't know if you guys had any thoughts on, what are things that you purposely go out of your way to do with your patients to help reduce stigma with them? What do you do for your coworkers? What do you do for yourselves?
One of the largest groups of people being stigmatized are people who are in long-term recovery on medication-assisted treatment.
Mhm.
They're being taught by just about everybody that they're never supposed to say that in public.
Oh,
They say they're on long-term recovery, they're doing great, they're on recovery, and everybody claps and is satisfied and happy. And but if they mention that they're on effective evidence-based standard of care treatment, everything goes downhill pretty quickly. And I'm just mentioning that it's a problem. I don't have a solution for it. But it's I do have a few patients around here in Shepherdstown who are very proud of their recovery and are very proud of the fact that they have achieved that through a long-term Suboxone. But those people are few and far between.
yeah. Thank you so much for sharing that. We hear that here as well for folks that are in the surrounding Morgantown areas that attend 12-step meetings around here. Some of them will say, there's meetings that I go to and I can be really open and honest about being on medication-assisted treatment, and they're fine with it and they support it and they don't really care either way. And then some of our folks will say that they sort of learned their lesson, that when they explained to people that they were in long-term recovery and in a medication-assisted treatment program, that there was definitely some initial backlash. That was one of the reasons that we helped our patient population start the BUPE group, and it takes place at Chestnut Ridge.
Yeah.
And I'm going to ask Douglas when I ask how old that meeting is.
I would say it's probably about 3 years old now.
3 years. Okay. See, I would have said a year, so I'm glad I asked Douglas. And it's specifically for people that are in a medication-assisted treatment program, and it's the 12-step philosophies, so they know they're going to be able to go there and not get judged for whether they've been in this program a year or 10 years. So I'm so glad you brought that up, that is a problem.
Yeah, and of course, you're referring to it in 12-step meetings and groups like that. I'm really talking to it in public. I'm talking about people getting in front of an audience, talking about addiction and possible recovery and treatment.
Yeah.
A much on another echelon of problems. But the people you're talking to at an audience like that are people, if you're talking to a 12-step group, they pretty well know what's going on.
Mm-hmm.
They're already in a level of recovery of some sort. That's because they're in that meeting. But trying to get people who really don't know where to go next or how to go next, I don't think we're doing that well yet. I don't know how.
Yeah. Yeah, very good point. Anybody thoughts on what he shared? Oh, yeah, sorry, go ahead.
One of the things that I like to do with patients who talk about stigma is to point out that there's some exceptional people and figures in our culture who have had addiction but have been important people in society, like George Bush, the president, had an alcohol use disorder and he's in recovery. And Oprah Winfrey had a cocaine use disorder and she's in recovery. And Rush Limbaugh had an opiate use disorder and he's in recovery. So these are all notable people who've achieved tremendous things and successfully lived good lives, productive, wonderful lives, despite the fact they had an addiction. And I think that kind of reframes it, that it doesn't have to have such a negative connotation.
Yeah, absolutely. Oh, that's a great idea.
One of the activities I do with the groups here at Canal City and Sissonville is we'll do a values-based exercise and pair them with guilt and shame, and we'll have them identify values and also look at which values are present now in recovery, which weren't present, or which were they not acting on in active addiction. And then were those values still there, though, and buried? Because we'll talk about how guilt and shame, even though they're uncomfortable to feel, they show us that those values were still there, and that they weren't a bad person, even during all of that. Just the self-stigma.
I love that. That makes me think, gosh, one day down the road, I could see it being useful, maybe in one of these echo calls where we sort of all talk about, like, what's your favorite group that you run, or, what's the group that you feel like gets the most, activity from your group members, or even an individual therapy session. I could see that being really helpful, because I can tell you I'm probably going to steal your group idea.
Yeah, feel free to. I'd use just like a list, which book it is. It's one of the ACT books with values. Actually it's the card sort, the values card sort, and we'll give everybody a copy, and they'll just start throwing out values, and we'll write it up on the board and go off.
Thank you for sharing that.
I know one thing we've been using amongst our medical professionals is really contrasting substance use disorders to chronic medical diseases. For example, they might ask us, well, why is your patient still on Suboxone even after 2 years? And we would say, well, hey, if I had a diabetic and they started them on metformin, would I tell them to stop the metformin in 2 or 3 years? And I think when we provide good medical examples like that, they kind of get it.
Mm-hmm.
That's been helpful for us.
That really, you know, I've only been here at Chestnut Ridge for 9 years. And when I first came, that was something that Dr. Berry really helped me with that. I don't want to give him credit because that makes or his mustache too big. But he really helped me recognize that, you know, sort of comparing it to so many other medical illnesses that people are more familiar with, that helps sort of give them a framework of comparison.
Another, along the lines of what you were saying about the language that's used, so like instead of a clean or dirty urine, a positive or negative urine. In the Coke clinic groups, I'll talk to patients about how I don't use clean or dirty in their drug screens because they're not a dirty person if they use. And so I like to say that to kind of say, you know, I think it's a bad connotation for use and talk about kind of their identity some, because I think how they view themselves is kind of the key to the problem with stigma. And so if you can change their identity, it has a big health outcome.
Dr. Hirschler, I am not making this up when I tell you I had AP coat today, and there's somebody in my AP coat who I think was out at Lakewood, and somebody else in the group had, I was just doing the check-ins for just the beginning of the group, and I was asking them how many days sober they had, and somebody said I had 3 days clean. And one of your patients corrected them and said, well, Dr. Hirschler would say that you're not a dirty person, you know, and literally that just happened this afternoon. So when you, like, that's a great example of when you share that with the patients, it sticks to them.
Yeah.
Oh, hi, Dr. Zhang.
I'm sorry.
You're fine. Dr. Zhang's joining us.
Just
You're fine.
It's scheduled at 3:30, so that's why.
Dr. Zhang, we're just finishing up a topic on stigma.
Oh, okay.
I know another thing our group has been doing a lot is trying to get our patients to focus on what makes them them, right? Because addiction is a disease, it's not who you are. And so we really try to draw out, well, what is your family relationship like? Like, what makes you a valuable member of society? Because it's really amazing when you first encounter patients in the group, they really think of themselves as no good and worthless and a total mess up. And that's not the case. They have a lot of value. So I know for us in Charleston, we've been really trying to work on self-esteem issues.
Oh, I love that. That's wonderful.
Let me ask you a question, Katie. So you were talking about the stages of change, the trans theoretical model, and of course in group therapy you have people in different stages, especially in the weekly groups, you know, or early recovery groups where someone might be kind of further along and abstinent for a while, and someone else, you know, maybe pre-contemplative but getting the medication to reduce their urges to use heroin or whatever, or sell their Suboxone to use something else. And so if you're targeting one person in the action stage and someone else in the pre-contemplative stage, I just wondered, you said that you shame them by talking about action when they're really in a pre-contemplative stage. Do you think that affects them that way if you're talking to a different person in the group?
Oh, great question. You know, I'll often try to teach especially, that's a really good point, especially if there's a group where they are sort of all over that model. It's not, you know, 95% of them are in one stage and maybe one person's another stage. If there's a group where they sort of all fit in that model, then to me, that's a great time to teach them the stages of change model and how we use that as a way to kind of help them objectively look at their group, just the group dynamics in there, and help them understand on an objective level that people are in different places. And that when we're, you know, talking about solutions or solution thinking for every person, that it doesn't have to be for them if that's not fitting for them. But I also think if I'm let's say Dr. Zhang's in the action stage and I'm talking with him about ideas, I'm not singling out Lawrence if he's not in that stage, but he may be hearing some things that I'm sharing that's going to be planting some seeds for him. That's my hope. As opposed to telling Lawrence, well, Lawrence, you're not where Dr. Zhang is, so do what you can to get there as soon as possible, if that makes sense.
Okay.
Thanks, Dr. Zhang and Lawrence, for filling in for my group.
You mentioned something about the war on drugs, which, and of course, then we have the business of trying to treat patients while they're imprisoned or in jail. And that's kind of a double stigma, isn't it? That they have two stigmas. One, they're people with addiction, and two, they're people who are felons or in prison.
Mm-hmm.
And the people who are controlling their future, who they are, what's happening to them, isn't us.
Mm-hmm.
It's not well-meaning clinical providers.
Yeah.
So a lot of bad stuff is happening there. And I hope maybe somewhere we can start getting the jails and the prisons to start treating these people like they have a disease. They, of course, like to use the word choice. They made a choice, and that's about as far as it goes.
Yeah.
Mm-hmm.
Did I just see in the news last week or 2 weeks ago that I don't know which state it was, but that a judge ruled that they had to be provided medication-assisted treatment medications in jail? Was it? Did I just see that? Anybody else see that?
Yes, it was methadone. Yes, that's right. It was only one person, but it made it a class ruling. So we'll see what happens with it. Good luck.
Yeah.
The idea, of course, one of the problems of the jail is, of course, the diversion in jail is what it is on the street 100 times over.
Mm-hmm.
And so the price of a Suboxone strip in jail is several times higher than it is out on the street.
Yeah.
And so direct observed therapy is obviously a better way to do things, so to speak. And so, but still, would be very good to be able to start these people in a humane treatment protocol and have them experience that while they're a captive audience, so to speak. And by the time they leave, they've experienced recovery on a level. That would be great.
Yeah, absolutely. Any other thoughts or?
One other thing, I'm going to be the devil's advocate here. So I don't think stigma is all bad.
Okay.
I think that stigma makes people with mental illness and addictions want to be healthy. And if there wasn't a negative connotation to the behaviors and to the pathologies that people have, there would be less incentive to be well. So I'm not sure how you frame that exactly. Do you follow what I'm saying?
I think so. Tell us a little bit more about that.
Well, so a patient is using methamphetamine and their family says they're the black sheep of the family and they're an outcast. And so one person may respond to that stigma and never grow out of it and never improve, whereas someone else will say, I don't want to be excluded from my family. And so they're motivated to get treatment and turn their lives around because of the stigma.
Yeah.
Sure.
I've heard that.
Yeah.
I have heard that. Yeah. I have heard that before. Kids. Yeah.
This is Bill in Charleston. Well, I think one of the differences is looking at the behavior, the behaviors as being bad versus the person being bad. Done a bad thing, but I'm not a bad person. I think that helps. That's the issue of accountability that she was talking about earlier. Or at least that's the way that I've tried to frame that. And it goes all along with the notion of shame versus guilt. If I've done a bad thing, I can change that. If I am a bad thing, there's no change. So that goes along also with what Dr. Bo was talking about with the self-esteem. It's really not about who they are. It's something that they have, and it's also not the entirety of who they are. It's only a part of who they are. They have a disease. They aren't a disease as well.
Yeah. Oh, thanks for sharing that, Bill. I like that. Yeah. Anybody else?
just one minor point. So much of this discussion on stigma, about half the time we're talking about the person feeling stigmatized, and the other half of the time we're talking about the community, the people, the surroundings stigmatize the person, that is, hold a stigma against that person. And of course, the solution of those is two different things. Yes, the person's sense of being stigmatized has to be addressed, but also the community has to get addressed too, and that's a different subject altogether.
Oh, you're so
I was just thinking of that in the context of the trans theoretical model, though. It seems that maybe we have communities of pre-contemplators, and you have different pre-contemplators. You have reluctant pre-contemplators, you have resistant pre-contemplators, you have ignorant pre-contemplators or uninformed pre-contemplators, and that's part of the issue, I think, with the community, is this, trying to catch all those different people, and that there's going to be resistance in different ways. One of the things I think that we haven't done is maybe educate the community about the nature of the Suboxone and Subutex and so forth don't really change level of conscious, or in a bad way. You don't get the intoxication effect. So
I love the idea of communities on the stages of change model. I know Dr. Berry, and I think probably some folks on this call as well have participated in some town halls over the years as new treatment centers or treatment providers were opening up treatment centers in their community to kind of talk about some of those, some of those misconceptions about what that treatment center was going to do for the community. And I think it sounds like sometimes it's been really helpful, and sometimes it's been borderline helpful.
All right, awesome, everybody. Thank you so much, Katie.
Oh yeah, thank you.
That's great. If you guys have any more questions or comments, you're welcome to throw them out there. I just wanted to take some time if anybody had anything they wanted to talk about. We don't have a case planned for today, so if you guys have questions or want to impromptu submit a case or discuss a case.
I have a general question about approach to pregnant patients. I think that's a special population where harm reduction takes a greater emphasis than perhaps in some other patients. And I just wondered in general how you guys are approaching pregnant patients. And I know we have a special clinic for that population, but some of them don't end up attending that, or they wind up in AP codes. So I just thought it'd be a worthwhile discussion about pregnant patients and the approach to that.
Mm-hmm. Do we want to let other sites sort of talk about how they handle that first?
Here in Canoa City, we just basically put them in a separate group. We don't have enough patients like WVU to do group pregnant patients, but what I've gotten over the years with presenting all my pregnant patients as sort of a protectionist plan is that we don't throw them out for almost anything except for if they get really out of control with recurrent benzo use. It's about the only thing, and even then it would be a you have to go to WVU thing is how I handle it. So we just escalate the penalties the same way we would with a non-pregnant patient to intensive mat or daily visits if they're breaking all the rules, and we just give them priority in and priority to not discharge them is the only sort of special things we're doing with pregnant women. Of course, by the new law, you have to also say that you offered them same-sex counseling.
I don't think I realized it was a bylaw.
It would be good sometime, a future session. we have a new detox crisis stabilization clinic facility, whatever it's called, opened up here. 7+ days, quote, treatment, end quote. And we also are opening, in the process of opening, a long-term rehab 28-day program. I'm not a big fan of either of those with moderate to severe opiate addiction. I don't think they play a huge role, but they're here.
Mm-hmm.
And they're required to offer, have available, make part of, I'm not sure what the phrase is, have MAT, medication-assisted treatment, to be part of their program. And both programs are struggling with that because they're not an outpatient clinic. We know how to do that in an outpatient clinic. They're also not a hospital, but the long-term rehab is going to have 48 inpatients with nursing staff giving their regular medications every day, just like nurses do on the wards in real hospitals. And I have no idea how that's supposed to work. And I've talked with them, and it's pretty challenging. It might be good to have somebody or a couple of people who are running a crisis detox center, and I know of one good one there in Clarksburg. To have them explain how that's done in the context of segueing them over to MAT as soon as they're discharged, or starting MAT while they're there. And the same thing for the long-term rehab. They effectively run, the properly run, the OFLAC approved programs, just to get us some wider experience for how we're supposed to do that. Maybe we're strictly COAT and we're strictly outpatient-based MAT programs, and maybe we can think a bit wider because these programs or other programs are supposed to be using MAT as part of their program.
Yeah, we can definitely speak to that either at a later time. Dr. Zhang, I don't know if you have any thoughts on that either.
So, for this program, let me ask you, Dr. Otis, is this a 21-day residential program, or what kind of program is this?
Oh, we lost him.
Oh, we lost him? Okay.
It's two different programs. One of them is a 28-day inpatient program, and the second one is a 7 days, 10-day detox crisis.
Okay, because we have a very similar treatment residential program here. It's a 3.5 residential treatment program, 28 days. Then we attach to the same building. We have a detox unit. We just opened it here in Morgantown. It's more like for people. It's a 3.7 level facility, but we send people there mainly. We're pretty sure we're very selective. We know those people do not have complicated withdrawal or complicated detox. So those people basically they're pretty young, healthy, and very short advent taper, or maybe just CWA triggered tapering protocol. So those people, what we do is we send them to this detox unit. It helps them a lot because they can be transitioned into this 28-day program very easily. So I don't know, because your program is 21-day inpatient program. So I guess it's kind of a little bit different. But
no, it's 28-day. I believe it's going to be 28-day. But it was originally designed without MAT involved, and MAT got sort of stuck on because of the new rules in West Virginia. So and they're different programs. One's on one side of the town, and the other's actually outside of town. It's not even in Martinsburg.
I see. Because we the situation I see a lot, because DDU, dual diagnosis unit, we have 12 beds, and we have a lot of readmissions, because we understand statistically for the whole country, only 10% of people seeking help, and actually 70% of people we see every day in our daily practice are relapsing patients. So what I see on DDU, we have a lot of readmissions. So a lot of times, because it's very hard to get them to a long-term rehab program. So it's because they have to go after detox, even if we put them on this MAT, Suboxone MAT. The problem is they go back immediately to the same living environment. So the problem is they basically they're either offered, or they just they stay with people actively using all the time. So a lot of times I think this 28-day program, since we started this 28-day program, I have seen definitely some changes, because a lot of people can be transitioned. We are lucky enough because we take people, a lot of 28-day programs, they do not want to take people on MAT. That's a big stigma, and we can, it's very much related to what we just discussed. So now we have this 28-day program. We have 30 beds open for those patients from DDU, and most of the patients are referred from DDU. Then they just go, directly to this 28 days. Then during these 28 days, we have a lot of, we have time to arm them with a lot of tools to help them with relapse. But in the meantime, we do have time to develop a good plan for sober living or different kind of living situation change. So I think this program could be very, very helpful. That's what I think, at least, for this population who are kind of frequently relapsing and a lot of readmissions to detox units. So I think it's very hopeful. Even that 21 days could make a big difference.
Yeah. Well, I hope it does. We need something here.
Well, if I can just take a minute, I was in Charleston a couple weeks ago, and I ran into an old boss that runs a 28-day male facility, and they are now doing Suboxone with Northwood and Wheeling, and they are not comfortable storing it on site for obvious reasons. So they have made a partnership with a pharmacy in town where they drive the guys down in their van every single day to do daily dosing. The guys pay a little bit more because the co-pays are more, but they have agreed to do that. So they're taking them down to the pharmacy every single day. A lot of work.
So
they're short-staffed.
It's a lot of work, especially when you have a methadone clinic patient. That's a lot more work, because you have to work with the methadone clinic, OTP. But the one lesson we have learned is we take people with Suboxone and MAT. However, before, because we send patients there and give them 28-day prescription of Suboxone, because nobody there would prescribe Suboxone. So then we learn a lesson, because we have some patients left after 2 or 3 days AMA. So just 2 or 3 days, but they're left with 25 days prescription. So that was a big problem. So we noticed that. Luckily, those 3 patients actually left AMA at early stage. They came back to the emergency room, and we just got them into treatment quickly. But so what we are doing now is we give them 1 week prescription, then we just renew it. So they leave with 7 days prescription. Takes the 7 days prescription to the residential place. Then we just renew it if they're still there. Otherwise, they don't get a prescription. They don't get a lot of films, with them to leave AMA. So that's something probably could be helpful for this new place.
Thank you, Dr. Zhang.
Thank you.
So just real quick, going back to the subject of pregnant patients in the Coke clinic.
Oh yeah.
We kind of got off.
We did.
Track there for a minute. So in Morgantown, of course, we have a clinic just for pregnant patients. And in that group, things are done a little bit differently. There's a little different rules, regulations, and things like that, such as we allow those patients to count OB appointments as a recovery meeting. It kind of gets them motivated to get to those appointments. What else can you think of?
Yeah, that's the main. I think they just try to keep their OB team and their OB treatment very connected to their addiction team and their work they're doing here. So yeah, so any kind of visits over there count for what some of their requirements are here. There may be a little bit more. They try to be more flexible with scheduling their individual therapy sessions to make sure that it happens. At one point, we would get volunteers from the nursing program that would come over and help offer childcare in those groups.
Education is also a big factor in those groups too. They bring people in to educate the patients on several different topics. So we have that program. Any patient that we have pregnant in the COAT program, we offer them to be able to go to those groups. Now, if those patients deny that and they stay in the COPE program, then we treat them exactly the same as we do every other patient in the regular COPE program. So they follow the same rules, same regulations. They'll get dismissed from the COPE program just as easily as any other patient in that program.
Mm-hmm.
But also we try to encourage prenatal visits. I think one prenatal visit can be counted as a meeting, something like that, right?
Yep. So that's in the pregnancy clinic. If they can count those in the pregnancy clinic, but if they're in the COPE program, they have to go to the same amount of recovery meetings and things like that. Any questions about any of that? Hopefully that answered Dr. Hirschler's
I forgot that question
question
a while
a little
ago.
bit.
Actually, I have a question about that. So do you have two full separate groups of pregnant patients? One is like COPE pregnant patients and one is non-COPE pregnant patients?
No. So we have a COPE group just for pregnant patients. We actually have 2 weekly groups that just consist of pregnant patients. But then we also have pregnant patients that are intertwined with the rest of our COPE program.
So a patient in my weekly group who gets pregnant while they are already established in that group, sometimes they don't want to move over to our pregnancy clinic because they know their group, they like their group, they know their doctor, their therapist, they would just rather stay there.
Yeah, just because we have a pregnant patient in the COPE clinic, we don't require them to go to the pregnancy clinic, but we offer that. So if they don't go to the pregnancy clinic, then we hold them accountable for the exact same rules, regulations, and so forth that we do all the other COPE patients. But if they go to the pregnancy clinic, then there's different things that's offered to them in that clinic. Does that make sense?
Yes, I'm curious about the difference, like what would lead you to be discharged from the special pregnancy clinic, or what protections do you have there that you're giving up to stay in the regular COPE clinic as a pregnant woman?
That's a great question. Some of this, what I might do is talk with Laura Lander, who she runs the pregnancy clinic. So I may run this by her afterwards, and I can kind of email you maybe what some of her specific answers would be for that. You asked a very good question, sort of what does it take to get dismissed from that clinic? I think it's a lot. I think they really try to sort of give folks chances and get them involved in additional treatment if they're struggling before they would refer them outside of that group.
Just because they're able in the pregnant, it's pregnancy specific, so they're able to focus more on the patient's recovery and also the pregnancy. Where in the regular COPE group, pretty much the only thing we're really able to focus on is the recovery. So they're able to focus on a lot more different things in that program.
I think the big areas that I'm not sure where to go on pregnant women is strongly suspected diversion and confidentiality breaches. It's one of the reasons I like keeping them separate. I don't have to worry about a confidentiality breach because I historically, in order to try to protect myself from CFR, have warned patients that breaching other patients' confidentiality I can't have them in my group program anymore, and they're out of the clinic.
Yeah, I'm not sure that's that kind of rule. I'm not sure that's a rule that we have different in any of our clinics, because that's a really important value for all of the clinics to hold on to. Yeah. I'm not sure that's one that the pregnancy clinic folks really would treat differently. I'm looking at Douglas as I say that, because I'm not sure I'm 100% with that answer,
Right.
but I feel pretty confident about it.
Do you remember, have we ever dismissed any patient from pregnancy group?
So from the pregnancy group, I'm sure that they have. I can't confirm or give a specific time that happened because I don't case manage the pregnancy group, but I can almost guarantee you that they have dismissed patients from that group before. Now, they're not going to dismiss them with a taper script, out to the streets or anything like that. They're going to refer them, or at least try to refer them to a higher level of care. such as our advanced probationary coat clinic or a daily check-in clinic or something like that. They're not just going to give them a taper script and let them go.
Maybe it'd be helpful to have Laura Lander email all of us kind of the philosophy and approach to pregnant patients in the Suboxone program.
Yeah, absolutely. I will make myself a note on that. That might be, she may be able to answer some specific questions, and that might be a good idea for a didactic in the very near future.
Yeah, we'll get that planned, and I'll make sure we send that out to everybody. Great, guys. Do you guys have any other questions or anything you guys need to talk about? We have about 10 minutes left. I think it's been a great discussion for not having a case. All right.
Well, thanks for your time.
Thank you.
Awesome. Everybody, let's see. Our next session is on, actually, no, it's canceled. Our next session is scheduled for Memorial Day, so we will not be having it on the 27th. So I'll email you guys that reminder, of course. If you guys do need anything in that time, feel free to send it in, and we'll continue to get to it, though. All right. Everybody have a wonderful day.
Thank you.
Thank you. So if people are interested